What really happens when HIV-positive blood enters your eye? Picture this. You're in a hospital, or maybe you're at home helping a family member who got hurt. There's blood, and before you can react, before your brain even registers what's happening, a single drop lands directly in your open eye. You blink, your heart stops, and then one thought rises above every other thought in your mind. Oh God, what if they have HIV? That moment, that gut punch of pure terror, is one of the most psychologically overwhelming experiences a healthcare worker, a caregiver, or an ordinary person can face. And yet, despite how common accidental blood exposures are, the CDC estimates that approximately 385,000 needle stick and sharp object injuries occur among U.S. healthcare workers every year alone. The vast majority of people have absolutely no idea what actually happens inside their body when this occurs. Not the myth, not the panic, the actual biology, the real numbers, the honest truth about what your body does, what medicine can do, and what you should do. That's exactly what the next few minutes are about. And I promise you, what you learn here will completely change the way you think about this. Introduction. Welcome back. If you're here for the first time, this channel is about one thing: taking the most complex, most misunderstood medical science in the world and making it crystal clear. No panic, no half-truths, no watered-down explanations, just evidence-based medicine delivered with the honesty and clarity you deserve. Now, today's topic is one that sits at a fascinating and frankly underexplored intersection of virology, immunology, and what clinicians call occupational exposure medicine. It's a topic that affects nurses, doctors, lab technicians, first responders, and even ordinary people in unexpected circumstances. And it is surrounded by more misinformation than almost any other medical subject I can think of. Here is what we're going to cover today. We'll start with how HIV actually works at a biological level, and I mean really works, not the oversimplified version. Then, we'll walk through exactly what happens step by step when HIV-positive blood makes contact with your eye. Then, and this is the part that genuinely surprises most people, including many medical professionals, we'll talk about the real numbers, the actual risk, and the science behind it. And finally, we'll cover the exact evidence-based protocol that the WHO and CDC say you must follow if this ever happens to you or someone you know. But here is the one thing I want you to hold in your mind throughout this entire video. I'll come back to it at the end. Write it down if you need to. The outcome of this scenario depends almost entirely on what you do in the first 2 hours. Almost entirely. Let's get into it. HIV, the virus that rewrites your DNA. Before we can talk about what happens at your eye, you need to understand what HIV actually is at a molecular level. Because HIV is not like most viruses you've studied or heard about. It is genuinely, biologically extraordinary, and understanding why is the key to understanding everything that follows. HIV, human immunodeficiency virus, belongs to a family called retroviruses. And here's what makes retroviruses unlike almost anything else in nature. They don't just infect your cells and reproduce, they rewrite your genetic code. They make themselves a permanent part of who you are at the level of your DNA. That is not a metaphor. That is the actual molecular mechanism. Now, HIV is a sniper. It doesn't attack randomly. It has one primary target, a very specific type of white blood cell called a CD4-positive T lymphocyte. You'll also hear these called helper T cells. And here's why that matters so profoundly. CD4 T cells are not just any immune cell. They are essentially the generals of your entire immune army. Every coordinated immune response your body mounts against bacteria, against other viruses, against cancer cells requires CD4 T cells to organize and direct it. When HIV targets these cells, it isn't just causing collateral damage, it is systematically dismantling your immune command structure from the top down. So how does it get in? HIV docks onto the surface of a CD4 cell using two specific receptor proteins, the CD4 receptor itself and a co-receptor called either CCR5 or CXCR4. Think of these as the lock and the deadbolt on your cell's front door. HIV carries the keys to both. Once it binds, it fuses directly with the cell membrane and injects its genetic material, which is RNA, not DNA, straight into the cell's interior. And now comes the extraordinary part. HIV carries an enzyme called reverse transcriptase. This enzyme takes that RNA and converts it backwards against the usual direction of biology into DNA. That's why these are called retroviruses. They run the genetic tape in reverse. That newly formed viral DNA is then escorted into the cell's nucleus, where a second enzyme called integrase physically cuts open your chromosomes and splices the viral DNA directly into your own. At that moment, that precise molecular moment, the virus is no longer a foreign invader sitting inside your cell. It is part of your cell. It is written into your DNA. It can lie dormant for years, hidden from your immune system like a sleeper agent, waiting. Or it can immediately begin hijacking the cell's own machinery to produce thousands of copies of itself, which then burst out and go on to infect more CD4 cells, and more and more. Research published in Nature has shown that within just 72 hours of initial infection, HIV can establish what scientists call a latent reservoir in long-lived memory T cells, meaning even if every actively replicating virus in the blood were eliminated, the blueprint remains encoded in those cells, potentially indefinitely. This is one of the central reasons why, despite decades of extraordinary medical research, a complete cure for HIV remains one of medicine's great unsolved challenges. Now, hold all of that, because the story of what happens at your eye is really the story of whether this entire cascade ever gets the chance to begin. What happens at the eye? So let's set the scene properly. You've had a blood splash to the eye. There's no cut, no needle, no visible wound, just blood on the surface of your eye. So what biologically is actually happening? The surface of your eye, that thin, transparent tissue covering the white part and lining the inner surfaces of your eyelids, is called the conjunctiva. And the conjunctiva is not skin. This distinction is absolutely critical. Intact, healthy skin on your hands, your face, your arms, that is a formidable, multi-layered barrier. HIV cannot penetrate normal, unbroken skin. Full stop. But mucous membranes are a different story. They're thinner, they're more permeable, they're designed for molecular exchange in ways that skin simply is not. And here is the ironic part of human biology that makes this so medically important. Mucous membranes, including the conjunctiva of your eye, are densely populated with immune cells, CD4 lymphocytes, macrophages, and particularly a type of cell called dendritic cells, including a specialized subset known as Langerhans cells, exist precisely to detect foreign material and initiate immune responses. But HIV has evolved over millions of years to exploit exactly this. When HIV-positive blood contacts the conjunctiva, the virus can interact directly with those surface dendritic cells. Those dendritic cells can capture HIV particles and carry them in an attempt to trigger an immune response toward the regional lymph nodes, where CD4 T cells are concentrated in enormous numbers. And in that lymph node environment, the replication cascade we just described can begin. Now, does this happen every single time blood contacts the eye? Absolutely not. The virus needs to be present in sufficient concentration. The mucous membrane needs conditions that facilitate viral entry. Minor abrasions, inflammation, or simple membrane permeability all play a role. And critically, the initial innate immune response, The body's first non-specific line of defense can sometimes neutralize the virus before it gains a foothold. But the pathway exists. It is biologically real, and that is why this category of exposure is taken seriously in clinical medicine, why it has its own protocols, and why it demands an immediate, informed response. The number that changes everything. All right, stop for a moment. Because right now, if you're like most people watching this, your internal alarm is going off. Everything I've described sounds alarming. A virus that rewrites DNA, immune cells being hijacked, dendritic cells carrying HIV toward lymph nodes. But here is the number that I need you to hear and really hear before we go any further. According to the Centers for Disease Control and Prevention, the estimated risk of HIV transmission from a single mucous membrane exposure, including a splash to the eye from a known HIV-positive source, is approximately 0.09%. That is less than 1 in 1,000. Now, I am not telling you this to make you casual about exposure. A risk that is not zero is still a risk, and this absolutely requires medical attention. But I am telling you this because understanding the actual evidence-based probability is what separates a calm, effective response from a panic-driven one that could paradoxically lead to worse outcomes. For context, the risk from a needle stick injury, which involves direct, deep tissue penetration, is approximately 0.23%. So mucous membrane exposure, while a genuine category of risk, sits at the lower end of occupational HIV exposure scenarios, according to prospective studies published in the New England Journal of Medicine, tracking healthcare workers after documented exposures. And here is where it gets even more nuanced, and this is something that genuinely surprises people. That 0.09% figure applies to exposure from a source with a detectable viral load. Because of a principle in HIV medicine that has been one of the most important discoveries of the past 2 decades, called U equals U, undetectable equals untransmittable, when a person living with HIV is on effective antiretroviral therapy and has an undetectable viral load, the risk of transmission drops to what researchers in a landmark Lancet study described as effectively zero. The partner study, which tracked tens of thousands of sexual acts between serodiscordant couples where the HIV-positive partner maintained viral suppression, documented 0 transmission events. 0. So the risk is not a fixed number. It is shaped by the viral load of the source, and that matters enormously for clinical decision-making after an exposure. Inside your body after exposure. Let's say, for the purpose of complete understanding, that viral entry does occur. What happens inside your body over the hours, days, and weeks that follow? The first phase is called primary HIV infection, or clinically, acute retroviral syndrome, and it is explosive. In the weeks following initial infection, viral replication goes into overdrive. Viral loads in the blood can climb into the hundreds of thousands or even millions of copies per milliliter. The immune system, recognizing this assault, mounts a fierce counterattack, producing HIV-specific antibodies, activating cytotoxic T cells to destroy infected cells, and flooding the body with inflammatory signals. This acute phase typically announces itself somewhere between 2 and 4 weeks after exposure, and it looks remarkably unremarkable from the outside. Fever, swollen lymph nodes, sore throat, profound fatigue, muscle aches, sometimes a diffuse flat skin rash across the trunk. The CDC estimates that up to 80% of people experiencing primary HIV infection will have some version of this syndrome, and virtually every one of them attributes it to a bad flu, a viral illness, a rough week, and never connects it to an exposure event. That is one of the most clinically dangerous aspects of this disease. It hides in plain sight, disguised as something ordinary. After this acute phase peaks and partially resolves, as the immune system brings early viral replication partially under control, the infection enters what's called clinical latency. The virus isn't gone, it is replicating at lower levels, steadily, silently, over months and years, and all the while, it is depleting CD4 T cell counts. A healthy adult has between 500 and 1,500 CD4 cells per cubic millimeter of blood. HIV, untreated, erodes that number relentlessly. When it falls below 200, when the immune army has been decimated to a fraction of its normal size, the body can no longer defend itself against organisms that a healthy immune system dispatches without even registering them as a threat. Fungi, certain bacteria, parasites, rare cancers. This catastrophic state of immune failure is what we define as AIDS, acquired immunodeficiency syndrome. But here is what I need you to hear just as clearly as I said that. This entire trajectory is entirely preventable. With modern antiretroviral therapy, people living with HIV today have a life expectancy that approaches that of the general population. HIV has been transformed through extraordinary medical science from a death sentence into a manageable chronic condition. And in the specific context of accidental exposure, with the right response at the right time, even initial infection itself can be prevented. And this is the moment in the video I've been building toward since the beginning. Most people who experience an eye splash with potentially HIV-positive blood are consumed by one question: do I have HIV now? That is the wrong question, completely wrong. The right question, the question that could literally change the entire outcome, is, do I still have time to prevent this? And the answer is yes, but only within a specific, non-negotiable biological window. Post-exposure prophylaxis, PEP, is a 28-day course of antiretroviral medications that, when started within 72 hours of exposure, can prevent HIV from establishing a permanent infection in your body. The biology behind it is elegant. HIV requires time to travel from the initial exposure site to regional lymph nodes and more time to establish the integrated DNA reservoir we discussed. PEP floods the body with drugs that block reverse transcriptase and integrase, the exact enzymes HIV needs to rewrite your DNA and entrench itself before that process can be completed. The WHO, the CDC, and UNAID all recommend PEP as the standard of care for significant HIV exposures. Studies in JAMA and data from occupational cohort research estimate that PEP, when initiated promptly, reduces the risk of transmission by 80% or more. The earlier it starts, the better it works. The 72-hour mark is the hard outer boundary of efficacy, not a comfortable guideline. The ideal window is within the first 2 hours, which means that every moment you spend at home, searching the internet, waiting to see how you feel, or talking yourself out of going to the hospital is a moment of real, measurable consequence. Myths versus facts. Let's dismantle the myths because there are a lot of them, and some of them are genuinely dangerous. Myth number 1. If HIV-positive blood touches your eye, you definitely have HIV. This is false. The transmission risk from a single mucous membrane exposure is approximately 0.09%. It is a real and serious risk that demands action, but it is not a certainty, not even close. Myth number 2. You'll feel something straight away if transmission occurred. Completely false. Acute retroviral syndrome doesn't begin until 2 to 4 weeks post-exposure, and many people experience minimal or no symptoms even then. Feeling fine in the days after an exposure tells you absolutely nothing. Myth number 3. Rinsing your eye with water is enough. Flushing the eye immediately with clean water or saline is the correct and essential first step per CDC guidelines, and you should do it for a full 15 minutes. But it is first aid. It is not treatment. It must be followed immediately by medical evaluation and consideration of PEP. Myth number 4. If the source patient has HIV under control, there's no real risk. This is partially accurate. A confirmed undetectable viral load dramatically lowers risk, consistent with U equals U evidence. But under control based on assumption is not under control based on current laboratory results. In an emergency exposure scenario, you do not assume, you act. Myth number 5. PEP is only for healthcare workers. False. PEP is recommended for anyone, healthcare worker or not, who has had a significant exposure to HIV. It is available through emergency departments, sexual health clinics, and HIV specialist services. And in many countries, it must be offered free of charge in emergency settings. The exact protocol that could save your life. If this ever happens to you, memorize what I'm about to say. First, immediately flush the affected eye with clean, running water or sterile saline. Do it for at least 15 minutes, gently, continuously. Do not rub, do not use soap or antiseptic in your eye, just copious, gentle irrigation. Second, stop whatever you're doing and go directly to an emergency department, occupational health service, or HIV clinic. Right now. Not in an hour, not after you've called 5 people. Now. When you get there, say these exact words. I had a mucous membrane exposure to blood that may be HIV positive, and I need to be assessed for PEP. Third, the clinical team will assess the exposure, the nature of contact, the HIV status and current viral load of the source if that information is available, and your own HIV status. They will then make a shared decision with you about initiating PEP. Fourth, if PEP is started, take every dose for the full 28 days. Do not stop early because you feel fine. Stopping early does not mean the threat has passed. It means you've left the course incomplete. Standard first-line regimens recommended by the WHO include tenofovir emtricitabine combined with raltegravir or dolutegravir. Fifth, follow up HIV testing at baseline at 6 weeks and at 3 months. With modern 4th-generation HIV combination tests, a confirmed negative result at 3 months is considered conclusive. Sixth, and this one is often forgotten, seek psychological support if you need it. The mental health impact of an HIV exposure event is real, documented, and taken seriously in occupational medicine. Anxiety, hypervigilance, and acute stress responses are common. You deserve care for your mind as much as your body. Conclusion and call to action. Let's land this. We started with a single terrifying moment, a drop of blood, an unprotected eye, a question that stops the breath. And here is what the science actually tells you. HIV is one of the most biologically sophisticated viruses ever studied, a retrovirus that targets the generals of your immune system, rewrites your DNA, and hides inside your own cells. When HIV-positive blood contacts the conjunctiva of your eye, a biological pathway toward transmission genuinely exists. That is real. That deserves respect and immediate action. But the transmission risk from a single mucous membrane exposure is approximately 0.09%, less than 1 in 1,000, a risk shaped heavily by the source patient's viral load, a risk that drops dramatically and potentially to near zero when the source is virally suppressed. And most powerfully of all, you have a 72-hour window and the medicine to use it works. Post-exposure prophylaxis, started promptly, reduces transmission risk by 80% or more. It is available, it is evidence-based, and it is the reason that in 2025, accidental HIV exposure does not have to define anyone's story. The real enemy here is not the virus. It's the panic that paralyzes people. It's the misinformation that convinces people to wait. It's the stigma that makes people too ashamed to walk into an emergency room and ask for exactly the help they need. You now know more about this topic than the majority of people on the planet, and knowledge, real, evidence-based, clear-eyed knowledge, is what saves lives in the moments that actually matter. If this video gave you something real today, share it. Send it to a doctor, a nurse, a paramedic, a medical student, a friend who works in healthcare, someone who might one day face exactly what we talked about today and need to know what you now know. Subscribe if you want more medicine explained like this. No filler, no fear, no agenda, just science and honesty. Stay curious, stay informed, and remember, understanding your body is the first act of taking care of it.